Okay, everyone, we're going to do some anatomy of the hip today. So this is our little hip model right here. By the way, if you guys have any questions along the way about the hip, just say something. I'll do my best to answer everybody, but we're going to try to be on for about maybe 5 minutes or so here. So the reason why we're going to be covering this today is because of a condition called hip impingement. Hip impingement, we're going to use this model as well as this little guy to talk about some of the important mechanical parts with it, but you should know ahead of time that you cannot change the structure of the hip. You will not change this bony anatomy. And so hip impingement is where the hip, if it goes into what we call flexion, or the hip goes up, then it runs into a little bit of a pinch point here in the front, as you see. So just take a note right here. As we move this guy up and flex him forward, he starts to kind of run into that section. And as you bring the knee across the body like so, kind of like you're bringing your knees together, the pinch point actually increases a little bit. And so there's two areas of typical pinch points. One is called the top here, which is called the pincer deformity, which is on a bone called the acetabulum, or part of the pelvis. And then you have this area here, which is called the cam, which this is a nice kind of ice cream cone shape here, but it can easily be a little bit more overgrown, which is more common with active individuals at younger ages. It is partially hereditary, partially not. We do have a video coming out pretty soon, which is going to cover all this in pretty good detail, as well as some of my exercises. So make sure you do subscribe to the channel, as that will definitely come up. So the first part here that you should know about hip impingement, other than just the bony prominences, is that you cannot change the bone. You will not need to shave this down. You don't need to shave this part down either. But what happens a lot of times is that the mechanics of the pelvis kind of gets in the way. And so a lot of times after old back issues, people tend to arch their back or stick their butt out quite a bit. And when that happens, it rotates this whole guy forward. If you look at this angle here, or this bone, it kind of rotates itself down, and it drops the rim onto a perfectly normal femur, or there's overgrowth here, and so it catches a little bit sooner. And they actually did some x-ray studies where they showed, though, with a anterior tilt, which is what this is called, it actually increased the amount of pain, decreased the range of motion available in just a basic squatting pattern here. And when you allow a posterior tilt to happen, which is normal mechanics for going through deep squat, the pinch point reduced because it rocked this whole guy back. Again, the whole point of changing how you feel with hip impingement is not necessarily to change those bony structures. It's to change how the interplay happens between the pelvis and the femur, and it kind of goes along hand in hand with some of the musculature, as well as core strength, as well as stuff down to the foot even. At least when we're looking into here, though, because I know a lot of you will have pain into, this is the front of the pelvis here. And you can see the joint capsule right here, and that's where all the impingement is, kind of right in there. And here is the hip flexor in front. And a lot of times people will talk about pain in the front of the hip here. And so they say, oh, that's my pain point. You know, it's right there. And so it must be my hip flexor. That's not always the case. By the way, if you guys have questions, general questions I can't answer one specific about your particular problem. But if you have some questions, I will do my best to answer whatever I can. So this pinch point here is kind of on myself. It's right here. We say that people have what we call the C sign, where they kind of put their hand right here and it hurts right into that area. So it's deep into this crease, and it hurts more when you bring the knee up and even across your body. But the problem is if you do the test, like actively, like I did, I brought my own knee up, didn't really use my hands to help. This hip flexor is active. And when it's active, people say, well, maybe this pain here is my hip flexor, and that's not always the case. It could be the bones, as we showed on the other model. It can be an overactive hip flexor. It can be stuff running over the top, which a lot of times there is conditions that are spine referred groin pain. But most of the time, hip impingement is the front. Now, the muscles here, again, this is the iliopsoas, which is both of them. And then you have this guy at my fingers called the iliacus. You can see as a reflection on this model here, the one that goes along the crest of the hip here, or the pelvis is called the iliacus, and then the one that goes, this one goes to the spine, is called the psoas major, which you can't really see the spine part in it right now. But we do see other muscles kind of popping up as well. And you can see the piriformis here. It attaches to the sacrum, which is removed from this model. And then if you look around the backside here, by the way, this is the area where people say they have this clunking, popping dancer hip type of syndrome. The muscles on the backside here, these are the guys, the deep rotators of the hip. As you see on this model here, we have the muscle that everybody blames, as well as the psoas is called the piriformis here, which is right here. This is where the sciatic nerve goes underneath it or through it, depending upon who you are. And then we have the superior gemellus, the obturator internus, the inferior gemellus, which is all kind of in this little mess right into here. The obturator inserts into this obturator membrane right here, which is in the, kind of the pelvic floor type of area. Then we said there's the ilium. This is technically like kind of the SI joint. This is where the sacrum attaches into here. And a lot of people will have pain into this area as well. And you can see that psoas or the hip flexor attaches into there. And then we have some gluteal muscles. You can see here the one on the bottom, or the deeper one, is the minimus. Then there's the medius, and then the one that's removed is the maximus. So medius, and then here's the tendon of the minimus, tendon of the medius. Here's the medius, and there's the maximus. Now the maximus is really an important one. It actually commands these guys quite a bit, and these guys aren't really strong enough to really control the femur right here. They do a little bit. They do stability, kind of like your single leg stance type of scenario, but they don't really do a lot of the work in regards to rehab. So usually the glute max here is the important one, and it actually comes down and it attaches to, they say 75% of the fibers attached to the IT band. The IT band runs down and attaches to the side of the knee. And if we look at this guy from the front here, we can see that, let's just say this glute max isn't really working, and it was not working well, so it's not tensioning the IT band well. Well, if the IT band, they say it kind of does this, or at least resists that, if it wasn't working well and it was allowing basically the knee to give way, it would create this inward knee presentation, and it would also create something called hip drop. This is what we see on runners. We see the kind of shimmy back and forth of a hip, but we also see knee cave too. And so runners are definitely ones that usually need better glute strength and better hip extension strength, which includes the glute max, which will mitigate problems like your runner's knee and your knee injuries in general. But overall, for hip impingement, the way that the glute max helps is it helps centrate the joint into the socket, and it also allows this posterior tilt to occur as well. So if you squeeze your glutes together right now, even if you're seated, but standing definitely works. If you squeeze them together, you kind of tuck your pelvis under. So you kind of tuck. So contract, tuck, contract, tuck. And you'll see that kind of happens. Now, it doesn't have to be that way aggressively all the time, but it allows for exposure to this, so there's not so much of a pinch point all the time. So a lot of times in rehab, what we do is we use various different tools and exercises to accomplish that in order to get this impingement to stop. Now, if you guys have questions on things, remember, we do offer telehealth, and we're licensed in different states, 714-502-4243, or you can go to p2sportscare.com. We'd love to help you through some hip impingement. Take care, guys, and if you like the video and you want more, please comment on it. It helps me understand what you guys want and gives a better idea of what to share later. Take care.